This is episode 82 of the Psychcast by MDedge, where we bring you interviews with leaders in the field, masterclass lectures, and relevant inspiration straight to your ears, with new episodes dropping on Wednesdays. I'm the voice of MDedge Podcast's Nick Andrews. Coming up later, a masterclass lecture on involuntary treatment with Dr. Dinah Miller, and Dr. RK returns this week with a few thoughts on fitting in. But we begin today with This Week in Psychiatry. Drazalma Sprinkle, which is a duloxetine delayed release capsule, has launched for the treatment of various neuropsychiatric and pain disorders in patients with difficulty swallowing. This is according to a press release from Sun Pharma. According to the release, the capsule can be swallowed whole, sprinkled on applesauce, or administered via nasogastric tube. Difficulty swallowing affects 30 to 35% of long-term care residents, but the main alternative, which is crushing tablets, introduces risks along the administration process. The sprinkle is indicated for the treatment of major depressive disorder in adults, generalized anxiety disorder in patients 7 years old or older, adult patients with diabetic peripheral neuropathic pain, and chronic musculoskeletal pain in adults. The FDA approved the capsule for these indications in July 2019. The capsule carries a boxed warning for suicidal thoughts and behaviors. The most common adverse reactions were nausea, dry mouth, somnolence, constipations, decreased appetite, and hyperhidrosis. You can find more on the story as well as a link to the full prescribing information in the show notes. It's time now for our Masterclass lecture with Dr. Dinah Miller.
Good afternoon. My name is Dinah Miller. I'm a psychiatrist in Baltimore, and along with forensic psychiatrist Dr. Ann Hansen, I am the co-author of a book called Committed: The Battle Over Involuntary Psychiatric Care. And so today I wanted to give a talk as one of the master classes called The Battle Over Involuntary Psychiatric Care. Does psychiatry have a role in preventing violence? And in honor of the president's comments last week, I think we recreated the subtitle to be with why asylums won't prevent mass murders. But the talk will be on a little bit more than just mass murders. So let me tell you how I got interested in involuntary psychiatric care, because it's not really a topic that one approaches a lot in private practice. But in 2006, Ann Hansen, Steve Davis, and I started a blog called Shrink Wrap. We thought it would be a blog for psychiatrists, but it turned out that over the 12 years we ran this blog and thousands of posts, that we heard from all sorts of people: psychiatrists, other mental health professionals, family members, and people who had been users of the mental health system. And we noticed that whenever the topic came to involuntary psychiatric care, the comments got really heated. People became very upset very easily. And I'll tell you that my view of involuntary psychiatric care was that people came to involuntary care when they were very sick. And you would think that they would be grateful for the care they'd gotten. And we were finding that really wasn't often the case. And so what I want to do is I just want to read you two vignettes. They are the start of the book, but they put a little bit of shape on this discussion. So the first person we talked to was a woman named Eleanor. And Eleanor starts with a case against involuntary psychiatric care, and I'm going to quote her. And Eleanor said, I'll tell you a little background. Eleanor suffered from her first episode of psychiatric illness in her 50s, and she was seeking care, went to the emergency room, sat in the emergency room for many hours, and decided to leave and go home, and then stopped at another emergency room where she wanted to sign in, but suddenly was getting medicated and involuntarily hospitalized because she was screaming at the top of her lungs. So she says, I would rather die than go in again. I'm not depressed, and my psychiatrist considers me normal. But I can't live through that again. The staff was abusive, demeaning, and dismissive. I felt in fear for my life. Any lack of cooperation was met with physical and chemical punishment. Several staff gave me the impression that I would never be released and would spend my lifetime forcibly retained and chemically blasted into oblivion. I still can't tolerate being in a car with closed windows because of the time spent shut in the confinement room with the lights out and no air circulating into the room. After several hours, the tiny room runs short of oxygen. I needed to lie on the floor with my lips next to the space under the door, trying to suck some air through the single crack. I was afraid I would die in there of suffocation. That ought to be illegal. Some of what they did to us should be illegal. And that's Eleanor's story. Eleanor did very well. She was never hospitalized again. She eventually came off medications and stopped seeing a psychiatrist. She was able to return to school for another certificate and start another career. She's a lovely lady. Lily is also someone who's felt more helped by her involuntary care. She had a little bit more classic of a course. She became ill in her 20s. She works, she lives on her own, she volunteers and works full time, but her story is a little more classic for a chronic psychiatric disorder. And she starts 9 years ago. I was involuntarily committed. I was extremely paranoid and afraid that people were tracking me down and that they thought I was a serial killer. My life was disintegrating at that time. I was completely paranoid, and my professors at grad school, and getting lots of incompletes. And I was accusing people of my job of weird things, then calling the police on them. The involuntary hospitalization was what got me started down the road to getting better. It was a stopping point from the spiral of psychosis and dysfunction that I was in, and it allowed me to realize that I was ill and to put my full force on getting better. I don't think I would have been committed if I hadn't had a psychiatrist who was treating me and a family who cared about me. I consider myself pretty lucky, even though the police came and brought me in. Nothing really stands out about the hospitalization itself. At the time, I was the most terrified I have ever been. And I just want to use those two stories as a starting point or jumping point. And so as we talk about the battle of involuntary care, over involuntary care, I'm going to talk about a few things. One is I'm going to talk about the organizations that have differing opinions about legislation pertaining to involuntary care. I'm going to talk about why some people find involuntary treatment to be traumatizing and some things we might be able to do about this. And I'm going to talk about a little bit about violence and suicide and the role that involuntary care plays as a public health intervention. So I have had a few observations over time, and I hope I can share them with you. But I've noticed that when people are involuntarily hospitalized, it's because they are acutely psychotic or they are acutely suicidal or both. And I've noticed that their symptoms decrease over the course of a hospitalization, meaning that when people are in the hospital, they get better. Wouldn't you expect patients to be grateful for the help they have received? So what's with this idea that care is traumatizing? When we talk about this battle, we're talking about four things that the battle is about. First, the standard for involuntary commitment to hospitals. And that standard varies by state. In the state I live in, you need to be suffering from a mental illness, and you need to be a danger to yourself or someone else. In some states, that standard includes being gravely disabled, and sometimes we talk about the standard for involuntary treatment being a need for treatment. And just to be clear, none of these standards is completely accurately or specifically defined. So it's a bit of our understanding of the words. And in addition to the issue of whether or not someone can be involuntarily committed, there's then the question of, is there somewhere to involuntarily commit someone to? So sometimes people meet the standard, but we just don't have the beds to put them in. The second thing the battle is about is outpatient civil commitment, or being able to require someone to get care, usually by a court order, when they're not an inpatient. So we call this, there are several names for it. It's often called AOT, or assisted outpatient treatment. Many people consider that to be a bit of a euphemism. Mandated outpatient treatment. In other countries, it's often called community treatment orders, or just simply OCC, or outpatient civil commitment. I just want to be clear, these are people who have not committed crimes. The civil commitment is through the civil court system. It's a different system if somebody has committed a crime and has gone through the legal system. And forensic outpatient mandates are a bit less controversial than it doesn't mean that somebody hasn't committed a crime, but they're not going through the court system if it's a civil commitment. The third thing is it's about the patient's right to refuse treatment and often medications. And the fourth thing, which I won't be talking about today, is a patient's right to refuse release of their psychiatric information to caretakers. And that one I'm not going to get into. So on this battlefield, this theoretical battlefield, I'm going to talk about the different stakeholders or groups that are interested in this legislation. And I'm going to start by talking about those who are more in favor of making it easier to treat people against their will, and then go towards the groups who are against having legislation that makes it easier to treat people against their will. So the first group I'm going to start with is the Treatment Advocacy Center, and they're really the group that most strongly talks about the needs of people with chronic and severe mental illnesses. They have a few messages. The group was started by a psychiatrist named Dr. E. Fuller Torrey, or Dr. E. Fuller Torrey, who worked at St. Elizabeth's Hospital in Washington, D.C., and he's the author of many books, and he talks a lot about involuntary treatment as a way of preventing violence. But the messages that the Treatment Advocacy Center has are that we need more state hospital beds. They keep track of how many state hospital beds there are per 100,000 population and publish reports. They're very much in favor of having a standard of mandated care for those in need of treatment, not dangerousness. They're a proponent of outpatient commitment laws, and they have proposed outpatient commitment laws in a variety of states. There are laws in, I believe it's now 46 states, though many states that have outpatient commitment laws on the books don't enforce them or don't actually practice them because of the technical difficulties of doing so. And they're a proponent of the idea that anosognosia justifies involuntary treatment. Anosognosia refers to the idea that someone who is psychotic or psychiatrically ill is not aware of the fact that they're ill. They don't recognize that they're suffering from an illness, and that this is something different than the psychological defense mechanism of denial, that it's a neurally mediated disorder. And the term comes from stroke patients who aren't aware of the deficits they have. But that because it's something neurally mediated and biological, that it's not a civil rights issue, it's an issue of treating someone because they're ill. The second group on the spectrum of groups that take a stance on legislation about involuntary care is the National Alliance on Mental Illness, or Nami. Nami is a grassroots organization started in the 1970s by the parents of people with severe psychiatric disorders, usually schizophrenia. Their mission is support, education, and advocacy. And over time, they've grown. So they now, last time I checked their, actually cut that there, they've grown, and their membership now is 180,000 paying members, and it includes patients and those representing the interests of those with less severe illnesses. NAMI has a bit of an identity problem in that they're not sure if they represent everybody with mental illness or those with severe and debilitating mental illnesses. And so they have conversations within their own group of whether they represent a big tent or a small tent, and representing a big tent gives them a little more leverage and a bigger body, but the original group that started Nami feels a bit left out, and like it doesn't leave them with a voice for serious mental illness. So this is their own internal disagreement, and it means that in some states, Nami is very much for in making it easier to involuntarily treat people, which is their traditional stance. And in other states and other areas or groups or regions, they're very much against involuntary care. So it's got its own issue there. I'm going to go on my spectrum of next is I'm going to put the American Psychiatric Association somewhere kind of towards the middle. The American Psychiatric Association consists of 38,000 psychiatrists. It is generally held dangerousness as the standard for involuntary care. And while they've really shied away from talking very much about involuntary treatment on an outpatient basis, in 2015 they came out with a very carefully worded stance in favor of outpatient commitment on a very limited basis. So I put them on the in favor side in my construction of this. Moving to the other side of the battlefield, the Bazelon Center for Mental Health is an organization that sees itself as being to protect and advance the rights of adults and children who have mental illnesses. They say they envision an America where people who have mental illnesses or developmental disabilities exercise their own life choices and have access to the resources that enable them to participate fully in their communities. They are not a big fan of anything that restricts the rights of people with psychiatric disorders to make their own decisions, which doesn't mean they're against involuntary care in all circumstances, but they are on the other end of the spectrum legally. I'm going to move over a little more on my battlefield to the recovery movement. And the recovery movement speaks to maintaining consumers' autonomy and having them take a proactive role in their treatment. The recovery movement has an emphasis on peer support, and it's a backlash to psychiatry as a paternalistic field where people with certain diagnoses were given dismal prognoses. The recovery movement often focuses on some of the words, and I use the word consumer, and I want to talk about that just for a moment to say that the words we use are important. Certainly we think of wording as promoting stigma, but in this battle, the words are crucial, so they provoke. So I'm a psychiatrist, I see patients. In the office next to me, there's a social worker, she sees clients. If you're talking in an advocacy or a legislative forum, we talk about consumers. And if you're somebody who was injured by psychiatric care, you may refer to yourself as a survivor. We talk about involuntary versus force, and we talk about medications, but some people talk about psychiatric drugs. And I'll tell you that knowing which word you choose, we generally know which side of this battlefield you're on. So if you're talking about force, you're against involuntary care. If you're talking about involuntary care, you're in favor of it, or you're at least somewhere in the more neutral range. But you wouldn't talk about a psychiatric survivor if you were someone who felt that psychiatric care was a helpful thing. Moving farther on my battlefield, I'm going to talk about two groups, Mind Freedom International and the Citizens Commission on Human Rights. And if you've ever gone to an American Psychiatric Association annual meeting, you might notice that there are picketers outside, people protesting the APA's annual meeting. And those two groups are the two groups that are doing this. Mind Freedom International was started by David Oakes in Boston in the 1970s, or in Cambridge. It was first called the Mental Patients Liberation Front, and Mr. Oakes started the group when he was a student at Harvard and was involuntarily treated. Their motto is win human rights in the mental health system. In 1986, they changed their name to Mind Freedom International, and they consist of psychiatric survivors who assert that they have been injured by the treatment that they have received, and they want to protect others from the same fate. The Citizens Commission on Human Rights, or CCHR, was started by a psychiatrist named Dr. Thomas Szasz. He worked at Syracuse, and he's the author of a well-known book called The Myth of Mental Illness, published in 1961. And in 1969, he joined forces with the Church of Scientology. They're a very anti-psychiatry group. They call themselves the Citizens Commission on Human Rights. And when I went to speak with them, when I was working on the book, they gave me an invitation to their exhibit called Psychiatry and Industry of Death Museum. And I think that says it all. I don't think I have to try to explain what a group that has a Psychiatry and Industry of Death Museum does. So these two groups are what I would consider anti-psychiatry. They're not just anti-forced treatment. They're they feel psychiatry hurts people. And the last group I'm going to mention is a journalist named Robert Whitaker, who wrote a book called Anatomy of an Illness and Mad in America. And his books assert that psychiatric medications aren't just ineffective, that they don't just cause problems, but that psychiatric medications are the cause of psychiatric illness and disability. And he has a group, in addition to the book Mad in America, where he talks about psychiatric medications harming people. He has a website and groups of people who write for this website. It includes a newsletter, and a number of the people who write for the website are psychiatrists and professionals in other fields. So I've laid out my theoretical battlefield for you. I'm going to make a few observations I've had about the world. And for one, we live in a world where opinions are sharply polarized. If you don't believe me, pick up a newspaper, but I think we all see that nowadays. We value autonomy in medical decision-making, and when there's controversy about the validity of a treatment, then there is even more controversy about forcing it on people. So if you start off with the idea that forced care is a good thing, that it helps people get well at times when they may be too sick to realize that they are ill, and that treatment enables them to stay housed, working, connected to their loved ones, and out of jails and institutions, then you do it a lot. It's a good thing. It helps people. But if you start off with the idea that forced care is potentially traumatizing in a way that leaves some patients, like Eleanor, with years of distress, which may dissuade them from seeking care later, perhaps when they need it even more, then you alter your threshold for committing people to involuntary treatment. But this issue is complicated. There are a whole bunch of different agencies at work here. We have the patient, who may be suffering and unable to believe they are sick, who ideally should have the right to refuse treatment. We have the family, who watch a loved one suffer, deteriorate, and miss opportunities, and who may be at risk of violent behavior. We have the mental health professional, who wants to do what is best for the patient, who wants to follow both legal and ethical mandates, and who wants to be paid, and who doesn't want to be sued for a tragic outcome. We have society, who may be at risk of violent behavior, and we have the taxpayer, who foots the bill for disability payments, lost productivity, and institutionalization. And finally, we have the insurer, who wants to pay for as little care as possible. So let's make some assumptions. Let's start with the assumption that psychiatric care may be traumatizing, and fears of involuntary or unkind treatment may discourage people from getting help. And my best guess is that anyone who treats patients who's in the audience listening to this has probably seen a patient who does not want to go into the hospital, whether or not they have been hospitalized before. There's fears about going into a psychiatric hospital. Let's also agree that it's never in your patient's best interest to seriously injure himself or anyone else, and that there are circumstances where there simply may be no other option but to commit someone to the hospital for care and to use force in order to make that happen. From the perspective of the treatment team, involuntary care puts us in the awkward position of being the adversaries to the people we are serving. So I've been talking for quite a bit now, and you may have noticed that I gave you absolutely no statistics. So let me tell you what we don't know. There's a wonderful website called data.gov where the government lists all sorts of data. So if you go in and you plug in, at least at the time I made these slides, and it may be a little outdated, but if you plug in frog, you're going to find 101 results for frogs. And you'll be happy to know that we spend money to put automatic recording devices on some of our wild frogs so that we can follow the wildlife. But at the time I did these slides, if you put in involuntary psychiatric treatment, there were 0 results. We don't know a whole lot about the effects of involuntary care. We don't even know how many people are involuntarily committed to hospitals each year. What we do know is that the standards in each state vary, and that in some states it takes an awful lot to get someone committed. You need to go through several agencies, several legal forms, and so it can be very hard to get someone in the hospital. In other states, it can be very easy, but there may not be beds to put them in. But this does change that the administrative burden of doing it does change how many people get involuntary care. So I want to talk a little about violence and mental health. And so anytime you read an article or hear someone talk about violence and mental health, you're going to hear the statement, people with mental health problems are almost never dangerous. In fact, they are more likely to be the victims than the perpetrators. And this quote is attributed to Senator Roy Blount, a Republican from Missouri. I'm going to give you a few statistics, finally. Psychiatric illness is thought to be responsible for 4% of violence. This comes from the epidemiologic catchment area study. Psychiatric illness is thought to be responsible for somewhere between 7 and 10% of murders. In any given year, approximately 20% of the population suffers from an episode of mental illness, and in the course of a lifetime, half of us will have an episode of mental illness. So in terms of violence, it's not a big percentage, but there are a lot of people with mental illness. What do we need to measure to even ask the question? Well, first, we have to ask what defines mental illness, and we don't have a set definition of that. Serious mental illness does have a somewhat set definition, but it's defined by diagnosis. And what defines violence, and how do we collect that data? So when we say people with mental illness can be violent, are we talking, we all agree if somebody shoots somebody or stabs somebody that we call that violence. But what if somebody slams a door or screams or throws an object at a wall or pushes someone to keep them from getting hit by a car? Sometimes these issues can be unclear. So there's a study done by the MacArthur Foundation. It was a slide that was lent to me by John Monahan for these studies, and it looked at violence in the 10 weeks after an inpatient stay. And compared to community samples, people with psychiatric disorders did have more episodes of however they defined violence. In fact, so for a 4% rate of violence in the community, they found that the patients with schizophrenia had an 8.1% rate. Patients with bipolar disorder had a 15.5% rate. Patients with depression had an 18.8%. And patients with personality disorders had a 22.7% rate. And sorry to read this to you, but I know you don't have something to look at there. I thought it was interesting that patients with schizophrenia had a lower rate. And I want to say that when you're talking about people with mental illness, people who have just been released from a hospital may not be very representative because, by definition, to get into a hospital, generally you have to be dangerous to yourself or to others. So it's a very small subset of people when we're looking at recently discharged people. This isn't this isn't people with mental illness overall. The other interesting fact was that in the second 10 weeks after discharge, if you looked at treatment, people getting more treatment were less likely to be violent. In fact, people being seen for more than one contact per month were less violent than the general population that wasn't being treated at all. So let's talk for a minute about mass shootings, because that really has been in the news lately. I'm going to tell you that defining it is complicated, and if at this point that's not surprising. But a mass shooting is an attack with a gun in a public place. From 1982 to 2013, the definition said you had to have 4 or more victims die. After 2013, the criteria was changed to 3 or more victims. So it's a bit of a moving definition here. You may hear that there's a mass shooting every day in America. And that's really not the case, because the definition excludes gang shootings, it excludes domestic violence, and it excludes shootings that occur during the commission of another crime. So it's an attack in a public place, generally on strangers. The shooters are usually lone males with 1.5 exceptions, and I say 1.5 exceptions. The ones that stand out are Columbine, where there were 2 young men, and the San Bernardino shootings, where a man and his wife committed a mass shooting as part of a terrorist attack. The average age is 35. Half or more of the people in mass shootings showed signs of mental illness, and most obtained their guns legally. There are two data banks for mass shootings. The FBI keeps one, and the Mother Jones publication keeps a really good chart of mass shootings since 1982. There's a huge amount of overlap, obviously. They're not completely the same, but I usually just use the Mother Jones one because it's very easy to access. So I'm going to suggest to you that we have a population of 341 million people in this country. If we cured all mental illness, we would still have 96% of the violence we have now. We would still have 90% of the murders. Violence is much more strongly correlated with substance abuse, anger, and early exposure to violence. From a public health standpoint, mental illness probably does not belong in discussions of violence prevention. And I say from a public health standpoint because that doesn't mean at an individual level. It doesn't mean that I think that if somebody walks into your office and is clearly violent or is talking about thoughts about hurting strangers with a gun, that you shouldn't hospitalize them if they have a mental illness, or that they shouldn't be reported to the police at some point. I'm just saying from a public health standpoint, this really makes no sense. Trying to prevent mass murder with forced care or putting people into asylums it's really like looking for a very specific piece of hay in a haystack, and you'd have more luck finding the needle. I'm going to make a provocative statement and say that from a public health standpoint, if you really wanted to prevent 90% of violence, you could prophylactically institutionalize all men between the ages of 12 and 65. And yes, I'm kidding, but it does work sort of on that level of what we're looking at. How about involuntary treatment for suicide prevention? It's thought that 90% of completed suicides occur in people with psychiatric disorders that have either been diagnosed or not been diagnosed, that suicide's often an impulsive act, and most gun deaths are suicide, not homicide. So 2/3 of gun deaths are suicides. We don't know if involuntary treatment prevents suicide, but it's awfully hard to let an acutely suicidal person leave your emergency department. Suicide prevention does belong in a public health discussion about firearms. So psychiatric care is about alleviating suffering and helping people to live full and productive lives. Involuntary treatment needs to take the individual's best interests, both now and over time, into account. So what's a mental health professional to do? You have a patient in front of you. And I would say that careful assessment with as many sources as possible and consideration of alternatives should be used before involuntarily hospitalizing someone. If they need to be in a hospital, try to engage the patient in voluntary care. If that fails, try again. Explain to the person the consequences of not agreeing to voluntary treatment, which may be even saying to them, look, if you don't sign in, we're going to have to involuntarily hospitalize you, and that just doesn't go as well. It's better if we're all on the same side. Coercion may be better than legal commitment, but I'm going to warn you, while my suggestions are well-intentioned, they may not work. If the patient can't be persuaded, consider alternatives that might honor their wishes. Does this patient absolutely need to be in the hospital? Is there no other choice than forced medication, seclusion, restraint? Can something else be done? If there is no other option, treatment should be forced. A traumatized patient is better than a dead patient. But I'm going to suggest that we need to be nice to involuntary patients. Not that we aren't generally nice to patients, but they are our sickest and most dangerous patients, and they will likely benefit from remaining in our care. And they may make us angry. They may be a lot of work. It may be an antagonistic treatment. An antagonistic treatment relationship makes for a troubling situation for the patient and for long work days. I'm also going to suggest that rigid adherence to policy may not serve us well. And I'll give two kind of quick examples, but people have rules. And sometimes when the patient doesn't want to follow the rules, force ends up being used. So something like, if lab work is needed and the patient is refusing it, they may end up being held down by guards to get routine lab work. And one might want to think about, is that really needed if the patient is not looking acutely sick? If this is somebody that you might have discharged if they could be seen in an outpatient setting tomorrow. And the other thing that comes up a lot is people get very distressed by strip searches or by body searches before they're admitted to a hospital. And some hospitals do this routinely, whereas other hospitals don't. And it's not at all clear to me why some hospitals need to do it and others don't, but this is something that troubles patients. And if you get a patient who's refusing, you may again be in a situation where they're being held down. And people take this as being very violating. Once the patient is in the hospital, obviously you want to minimize the use of physical force. But I'm going to tell you that we've gotten very good at minimizing restraints. Not quite as good at minimizing seclusion, but we don't use restraints very often. And the downside is that psychiatric hospitals have become more violent places. There are more attacks on staff members and other patients because we're not always very good at predicting who might become assaulted. I'm going to suggest that small acts of kindness are often greatly appreciated. And speaking with people as I was writing this book, many people pointed to just like the nurse brought me a cup of tea or somebody drew me a bubble bath, and that helps. Ask people at the end of their stay for feedback, and ask them without being defensive or telling them why they needed to be in, and acknowledge that it was hard. I think letting people vent is helpful. Give the patient kudos for their hard work in getting better, even if it was a rough journey for everyone, and give kudos to the staff too. This is just a hard situation. What could make involuntary care less necessary and less traumatizing? And I'm going to tell you that the thing I heard over and over again was that we tend to not have easy access to voluntary treatment. People have trouble getting appointments. People have trouble getting hooked in with care. And so they end up getting sicker and sicker until it becomes a crisis. So making voluntary care easier and more accessible early in the course of an illness would help. Police training to minimize injuries, death, and embarrassment, and to increase patient cooperation. I know that people feel like the police shouldn't be involved, but the truth is they are. We need better medications with fewer side effects, and we need to decrease stigma. And I want to point out to you that it's very hard to decrease stigma when you have legislatures talking about how we need to increase forced care to prevent mass murders. And a final thought, I just want to say that it's a little bit crazy that we invest so much in the discussion and legislation of involuntary treatment when there are so many people who want what we have to offer, but are unable to access voluntary care. Thank you so much for having me today.
And that concludes the lecture portion of our program. This episode is complete with show notes that include an outline of the lecture and links to relevant material referenced in the lecture. Coming up next, a few thoughts on fitting in. Welcome back to the Psychcast. I am Nick Andrews. It's time now for Dr. Renee Kohansky.
Appreciate the introduction as always, Nick. Being left out, fitting in. Somehow all roads always lead back to those darn childhood years. How many movies do we see where the dorky young kid is transformed to that beautiful swan of today? Take a second and think of how many you can name. No, seriously, I bet collectively we could get together and write our own award-winning movie script. Well, at least how many of us secretly fantasize that we could write that award-winning movie script? What made me think of this was a Group X class that I took. I arrived late and I occupied a mat that was somehow just a few inches outside the group. So my usual witty remarks, or at least what I perceive as witty, were met with, "What did you say, Renee?" And you know, in our business and in life, truly, timing is everything. And once the process started, it continued throughout the entire class. Every quip I'd make in return would be met with a, "What? We can't hear what you're saying, Renee." And for a moment there, I was transformed to the shy, skinny kid who had moved from the Bronx in the 3rd grade into a well-established group of kids who had been together since the beginning of time. Well, at least the beginning of time since as far as any of them were concerned, and they really didn't have need for anybody else in their group. Gone in a microsecond was the confident, competent, successful physician of today. Now, fortunately, I have an excellent observing ego, and I watched all of this unfold before me. So I did what I do best. I used my higher defense mechanism of humor, and I shouted, and yes, I mean I shouted, that I must sound like that teacher from Charlie Brown because all that seems to be coming from my end of the room is womp, womp, womp. And you know what? That's all it took, and I was back to being a grown-up and back to being part of the group. So, how much of the work that we do is about healing our patients from that sense of feeling like other? And this brings me back to my basic truisms. We are all wallpaper in each other's life. None of us get out of this alive. And all of us, every last single one of us, fear our own weirdness, our own separateness, and aloneness. We try to find our little places of safety where we can be accepted and loved. I am ever always humbled at how much we all want to be accepted. We all want to be part of the group, and how little it takes to shatter that sense of belonging, even as grown-ups. And it's not just human beings, it's in the animal kingdom as well. And in the animal kingdom, not being part of the group can mean death. I think the loving kindness meditation is a wonderful way to help everyone access this vulnerability in an indirect way, and a safe way, and a way to become more inclusive overall. I'm Dr. Renee Kohansky for the MDedge Psychcast.
Thank you, Dr. RK, as always. Well, that's a wrap on the 86th episode of the Psychcast by MDedge. It's time now for the credits. The Psychcast is hosted by MDedge Editor-in-Chief Dr. Lorenzo Norris. Our lecturer this week was Dr. Dinah Miller. The Psychcast is produced by audio producers Gina Henderson and Jeff Bauer. All MDedge podcasts are produced by executive editors Denise Fulton and Kathy Skarbeck, MDedge multimedia editor Terry Rudd. Our social media is produced by Kyla Clark. and I am the audio engineer, audio editor, and the voice of MDedge Podcasts, Nick Andrews. Thanks for listening. Episode 86 of the Psychcast by MDedge.